It's been about 2.5 months since I've addressed this group, and in that time, a lot has happened. Omicron came in with a fury, has begun to wane almost as fast as it came. So we have a lot to talk about, and I'm going to dive right in. We'll start with case trends and sort of where things stand right now in the US and in Massachusetts. And in the US, we saw this rescaling of the y-axis where we had to cope with suddenly many hundreds of thousands, probably over, if you count cases that were missed, clearly well over 1 million cases a day at the peak, but a relatively sharp decline afterwards as well. Hospitalizations also reached an all-time high in spite of the rumors that Omicron was milder. I'll have more to say about that in a moment. And deaths exceeded the peak of Delta, although they did not quite reach our all-time high, but have been greater than 1,000 deaths a day every day since August. Like literally every single day. The only exception was some reporting blips over Thanksgiving, but otherwise that has remained unfortunately steady. The per case rate was obviously much lower in Omicron, but that's thanks mostly to immunity. But the good news is right now, if you trace this back, we are at the lowest case counts that we've had since July, late July, the early part of the Delta wave, and we're continuing to drop. In Massachusetts, we have fallen roughly the same timetable. We're about the same as late July. But what that means is that we're actually 40-fold down from our peak, which is even more than the US had declined. Hospitalizations, deaths are continuing to trend. And this is really important. It means that we are a lot less likely to encounter SARS-CoV-2 than we were just a month and a half ago or 2 months ago. And this 40-fold reduction in that likelihood of encountering it is so much more protection than we would have gotten from masks. It's more protection from infection than we would have gotten from vaccines, but of course not from severe illness. And the thing to keep in mind though is that this is not guaranteed to stay, right? This can change, and if it does, then the scenario changes. But right now, the amount of protection we have from case rates this low is hard to overstate. It's amazing. And I'd say it's a little bit mysterious, and I think I come back to that in a minute, because what I wanted to do is reflect for a moment, even though it's nice that cases are down, on what we've learned from the Omicron variant. And I have more on thoughts on mitigation measures and other things that y'all have asked about for later, but I wanted to spend a minute just reflecting. So this variant took over faster than anything we've seen. And Delta was a really formidable virus, as you all who have watched my takes on this over the months know. And this just pushed it aside like it wasn't there. So Alpha took a few months to rise to dominance, Delta similarly faster than Alpha, but still on the scale of months, and Omicron pushed Delta aside in weeks. And each one has replaced a more successful virus, right? So this was remarkable and led to this tremendous surge of the sort that we hadn't seen before in terms of magnitude. But what comes next? Well, the first thing to know is that even though vaccines did not do as much as we had hoped, they still work quite well, especially against severe disease. So you can look in the US and you can look in the UK. In the US, even looking in the month of January, where everything has been Omicron, cases went up, even cases in boosted people went up, but not as high as they did in vaccinated people, and deaths are barely able to be registered in boosted folks, did trail up in all comers, but much more so in those who are vaccinated. The distinction that is made both based on in vitro data and the in vivo data that we have is that boosted for Omicron is like just sort of primary vaccination used to be against Delta. You look at the primary series and you're even against hospitalization, you're only in the sort of 40 to 60% range and waning. But once you're boosted, you're up around 80 to 90% again against Omicron and hospitalization. So really, if you've been listening to me this long, you're probably boosted, but if you're not, you should really think about it if you're eligible. So when there are new viruses, variants that come through, the way that I try to think about it are in terms of viral factors and societal factors. The viral factors include transmissibility, which I try in my mind to put in a hypothetical society without immunity, just like how good is the virus at getting along. That's less and less relevant because society has a ton of immunity to SARS-CoV-2 now, but different amounts to different variants. I think it's much more important even to separate out intrinsic severity as a property of the virus. Again, imagine a hypothetical society without immunity, because that's important because there are a lot of people like that still. There's enough that 1,000 of them are dying a day, and most of those folks are folks at least without functional immunity. Some of that's immune suppression, some of that's people who just haven't been vaccinated yet. So I think it's important to try to separate this out. And then the third property is immune evasion. So how good are these viruses at these variants at getting around the immunity that we have? And then there's societal factors that affect how much a variant will impact us. And that includes effective population immunity against that variant when the variant hits. It includes the sort of age distribution in the society and comorbidity burdens. But fundamentally, really, a lot of it comes down to what fraction of society at each age group has seen spike before. That really matters in terms of the impact that these variants have. And I think that explains a lot of the differences we saw from one society to the next. And then what mitigation measures is that society putting in place? And then seasonal factors, which I think we really underestimate, but I think have played a big role. Okay, so for Omicron, really quick highlights, because I want to get through a fair bit of other material, but the transmissibility is very high. It's as good as any other virus that we've seen, even on its own. I think the best estimates, trying to set immunity aside, immune evasion aside, are that it's still just as good as Delta, at least, at just getting around, even if there were no immunity. The intrinsic severity, higher than you think. I'll come back to that in detail. It is slightly less bad than Delta, probably worse than any other variant before. And the headlines that have called it mild, I think, are sort of asking the wrong question. And I'll come back to that for a little bit, because I think it's a really important point. And then immune evasion is by far the highest for this variant than anything we've seen before. And that really, I think, if there was one property that defined what it was able to do to our society, it's this one. There's been variable, obviously, population immunities, obviously age and comorbidities are variable from place to place, mitigation measures too, even within countries, but they're in general less than what we've seen before. And then the other thing is that winter is peak coronavirus season. I think that made Omicron uniquely bad. Okay, so immune evasion, really quickly, I think I'm not going to summarize the data. I actually went through this in my last talk. I think that holds up pretty well, that both in vitro in terms of neutralizing titers and in vivo in terms of efficacy, this is just a different beast that is much more able to get around prior infection or prior vaccination. The best sort of one picture summary I've seen is this antigenic cartography, which I put the details in the corner, but just take my word for it that like, this is roughly a map of antigenic distance. And we were worried, I was worried about Delta being a little bit immune evasive and Beta being immune evasive. Omicron is a new ballgame. It's just much farther away, right? Whether this becomes a new strain or whether it has further to go before we start labeling things strains, I think is an open question. But this is a very distinct virus antigenically, and that had big impact. And then severity. So I don't want to belabor this too much. I wrote about it with Bill Hannage. You can find this paper. This is as clear as I could say it was in that paper. But basically, Omicron hit a society that had seen more SARS-CoV-2 than any prior variants had, right? And so we tried to mock that up for South Africa here, where people in orange are non-immune and people in blue are immune. This is about what the society looked like when Delta came through. On the left and on the right is what it looked like when Omicron came through. So many more immune people in blue. But furthermore, it is much better at infecting those people with immunity. So that actually, these compound each other. So if you look on the sort of the vertical axis, we show immune efficacy, where there's about an 80% effectiveness against Delta for the kind of vaccines or prior infection that was in South Africa. It's down to like 25% because nobody in South Africa was boosted for Omicron. And so what you see is that because there are more immune people and a virus that's better infecting those immune people, you get a lot more infection in people with prior immunity. And that even if the virus were just as bad, you would see much less severity because the people in blue are less likely to get sick. They have seen this before, it's not novel. And so much of the mildness or milderness that the media discussed is really a result of our immunity and not the virus. And the reason I think it's so important to separate these things is that doesn't apply to everyone. That's not a property of a community. It is a property you can describe about a community, but fundamentally severity is an individual thing. And many people have not seen spike before. Most kids under 5 haven't, except those who have been infected before in the US. And most people around the world haven't been vaccinated. And there's immune suppressed people. And so I think it's important to parse these out. Turns out it's probably a little bit like 25% milder in non-immune people than Delta was, but worse than anything that came before. So important to remember. So my key takeaways, I didn't get into the details of this, but one thing is that the spike and the interface between the viral spike protein and our ACE2 receptor is really flexible. I think more than I appreciated before Omicron came along. I didn't know you could tweak so many amino acids at once and still have a functional virus. The fact that it's done this as many times as it has, I think it would be foolhardy to say it's not going to be able to do this again. At some point, we may reach that limit of sort of binding modes, but I don't see any reason to think we're there yet, so there may be more. The other thing, boosted is the new vaccinated. You want to have seen spike as many times as possible. So SARS-CoV-2 going forward is less novel to our population. Actually, Omicron put us into a new stratosphere. Maybe 50% of the US has been infected by Omicron just in the last 2 months by some estimates. So this, I think, is going to durably make the average case less severe, but it's still really important to think about individual risks. My 3-year-old son, I don't think, has seen SARS-CoV-2 before in any form. Immune suppressed people who can't mount a response to vaccines similarly may still be at very high risk, even though the society, I think, is going to get, each wave, I think, is going to have successively less per case effect. But I think it's really important to tease apart the nuance there. And then again, I'm not sure why it faded quite as quickly as it did. Some of it's clearly accumulated infection. We had a lot of baseline infection to begin with. A lot of people got infected by Omicron, and that induced Omicron-specific immunity. I think there's a role of seasonality, though. I think I pulled the slide for time, but most human coronaviruses that cause common colds anyway, they stop circulating in about mid-February, and we don't really understand why. Maybe even sooner than that for some, like peaks are in January. And so that's what happened last year also. We sort of had this remarkable decline in mid-January, and we saw it again. And so some of this may be seasonal, and that obviously may reverse come winter. So stay tuned. Either new variants or other sort of changes in whatever factors made this go away, they're not promised to be forever. So now moving relatively quickly and looking at the clock, there is a new variant already on the horizon, or at least a subvariant. It's called BA2. It's already taken over in a few places, and I think we can learn what it might do in the US from what it's done there. In South Africa, it came on as now nearly 100% of their cases. It's as different from Omicron, from BA.1, the sort of first Omicron that we saw, as the other variants are from each other. It's got like, on the order of 10 or dozens of amino acid changes. And so it took over because it's better, it's more transmissible, at least in this current environment, than even Omicron. But it did so after cases had kind of come down, and it slowed the descent, but it didn't cause a new wave. In Denmark, on the other hand, it rose to dominance right in the middle of a surge, and it made that surge actually considerably worse. I think in the US, we're actually going to be a little bit closer to South Africa, even though our season is different, because the Omicron wave is more like this, and it's still not even at dominance. So I think it's here in green, just starting to rise. Probably if it does here what it does elsewhere, it will take over by like April. But my hunch is because it will come at a time when we've already gotten a lot of immunity to a closely related virus. I think it may slow the descent. It may cause a small bump. It's not going to do what Omicron did, I think. Time will tell. Relative severity looks about the same. That's really hard to tease apart. But I think if you believe the corollary that immunity is a lot of the reason that these things are getting more mild, that should at least still be true. So I'm hopeful we're less at the whim of the sort of viral variation. But we need to study that closely. All right, mitigation measures. As I'm sure you all know, the CDC recently changed its recommendations, and many states have either led that or are following that to sort of pull back on mask requirements as cases are dropping, not even sort of waiting for them to hit a new plateau of low. Why is that? Well, so the perspective of at least the CDC guidance is they've changed from case-based guidance, just about a sort of number of cases per population, to what they call community level based guidance, which is a sort of mashup of case incidence and hospital capacity. They recommend that if in areas of low vaccination, low community level, which includes Massachusetts, most of Massachusetts now, it's by county level, that all you need to do is be vaccinated and get tested if you had symptoms. And it's not until you get to medium or high levels that you're talking about masking if you're high risk in medium environments, or masking for everyone in high risk, in high transmission environments. I personally would, if you're at high individual risk of severe illness, I personally would keep a mask on at all times. And my sort of take on this is that this reflects a shift in focus away from minimizing the risk of COVID infection towards minimizing the impact of COVID infection on society, right? So like we have metrics now that avoid crushing hospitals and things like that. And so this is not, in my view, individual guidance. If you're immunosuppressed, if you're unvaccinated or unexposed for whatever reason, or if you live with or frequently see someone who is, you may want to keep masking, even in low environment settings. I think that's totally rational. And in that case, since others around you will be less likely to be masking, at least in a state like Massachusetts, where that was even still going on, you might think about a better mask. So N95s are actually getting much more comfortable. There's a couple of models, the 3M Aura, the Halyard Duckbill. I get no money from either of them, but my colleague described especially the 3M Aura as the sweatpants of N95s. They're tremendously comfortable. They get you a better seal. They don't fog your glasses. So as a one-way mask, if no one else is masking, the N95 gives you better protection. This is what I wear to go in the room of a patient who I know has COVID. This is what I did before there was vaccines at all, right? And so this is good protection if you can get it. And so you may want to think about that if you are one of these people in that situation. I wanted to spend a moment on new treatments, just to say that this is another thing that's changed and I think has something to do with the recommendations changing. Monoclonal antibodies, we've known for a while, work great, but they are actually less likely to work against Omicron. We know this from at least in vitro data. They also have to be given intravenously or intramuscular, so they're a bit inconvenient there, but only a small handful still work. The problem with them really is that the selective pressure that a society's like sort of collective immune response exerts on the virus is basically the same selective pressure that, like, if a virus evades our sort of society's immunity, it's going to evade these monoclonals for the most part. You know, we can try to find second generation drugs that are a way around that, but at a first approximation, it's the same selectable target, right? It's the spike protein. Nirmatrelvir and remdesivir, on the other hand, they target a viral protease or the RNA-dependent RNA polymerase, which are not the targets of our vaccines anyway, and probably not major immune targets either. And they look really effective too. And in fact, nirmatrelvir is orally available. Remdesivir has to be given IV for 3 days. But these are really promising. There's a lot of drug-drug interactions. We have to be cautious with nirmatrelvir. But this is similar, like 85 to 90% reduction in hospitalization in high-risk patients who take it early. But it's key, they're antivirals, all of them. And so they have to be given early. This means you have to test. If you're at high risk, you should know this, you should have tests ready. And if you test positive, you should find a way to get in contact with a provider to get treatments as early as possible. But this really, really reduces hospitalization risk. And I hope that that the resistance to especially these non-spike targeting therapies should be slower than we saw to monoclonals. I think it'll happen, but I'm not sure they'll spread. It's sort of a nuanced question. I'm hopeful that these will last for a while anyway. There's no data on any of them in Omicron, but I would think that the non-mAbs should work against Omicron. Its protease and RNA-dependent RNA polymerase are not functionally different as far as we know. There's no data in vaccinated people either. And I think we sort of have to extrapolate there to at least immunosuppressed vaccinated people. It'll likely help them too. But we formally have not studied them in that population. Okay, so quickly your questions, and then I will turn it over to Jesse. Several people I think asked about kids and vaccines. This is close to my heart. You may have heard some splashy headlines about data in 5 to 11-year-olds not looking as promising as it was in 12 to 16-year-olds. You may have missed the sort of lack of headlines about a CDC study that was released maybe 2 days later that actually had the opposite conclusion, that it's about as effective. So in general, I'd say stay tuned, but I have no reason to think that it won't work. It probably won't work that well against Omicron because nobody in that age group is boosted, and unboosted vaccines don't work that well against Omicron, but they should hold up in severe disease. That's my best prediction. And then less than 5-year-olds, I have a 3-year-old son. This has been a source of frustration for me too, but just to boil it down, the initial round of the trial did not meet immune equivalence to 16 to 25-year-olds, which was their initial pre-stated goal. I think it's very unlikely that unvaccinated kids, it's probably true that even that lower dose vaccine would be better for kids than just getting COVID unvaccinated, but we can't really approve drugs that way right now in our society despite the pandemic. And so that had to be put on pause. We're hoping, so they added a 3rd dose to try to boost the antibody levels further. Hoping for a readout for that soon, although I haven't heard word on when. And in terms of folks asking, I think there were folks asking like, what's my take on this? I expect, assuming data show antibody levels in the right range and no new safety signal, to vaccinate my 3-year-old kid as soon as he's authorized to receive it. It's a top 10 cause of death in kids. There have been 20 pediatric deaths per week since December, and nearly all in the unvaccinated people. It's a vaccine preventable top 10 cause of death in all likelihood. I can't wait to give it to my kid. Someone else asked about J&J and boosters. First of all, if you got J&J, please boost. But the question really was, if you did already do that, should you boost again? There's not a lot of, there's actually no data I'm aware of on a repeat boost after J&J. But if you look at antibody levels, J&J and then an mRNA vaccine gives you pretty good, this is against Omicron, gives you pretty good Omicron neutralization. If you went J&J and then J&J, not as good. But for the rest of them, it gets you into a pretty good range. So I think you're data free going beyond that. There's some data that J&J may be more durable. I don't know that you have to boost there. In vivo, at least efficacy against severe disease after boosting looks good. So I think by and large, this is, it's probably against infection. It's probably a little bit less good than 3 mRNA vaccine doses, but it's probably J&J and then an mRNA is probably better than 2 mRNAs. So to summarize, I think the key questions are how long this lull will last. And I don't think that we really know for sure, because I think to some degree, we don't know why it came down. But I think that unless a new variant comes along or seasonal factors change, if it's just from waning immunity, that should be a gradual process. But the transition, I think all of this is going to be gradual. And when we're in like an endemic phase, will only be clear in retrospect. I think there will be bumps along the way, and we may need to adjust mitigations in response to that. No reason I can see to think Omicron will be the last variant, but it depends on the flexibility of the spike ACE2 interface. I hope we update vaccines as a society. I don't know how we'll do that. You might imagine doing that in the winter. You might imagine doing that for the Omicron variant or the next variant, maybe multiple variants mixed together. But in general, we have as a society, the virus is less novel to us, and that's going to help things. It won't help everyone. If you're immunosuppressed, you need to remain vigilant, unfortunately, and for the foreseeable future, I think, but treatments should help there.